All right, let's crack the code on heart failure. Especially if you're a clinician in training, you know that getting a handle on this syndrome is step one. But how we classify it is everything. It's the critical first move that guides every single treatment decision we make. We're going to build a really clear framework, starting from the ground up.
Here's our game plan. We're going to walk through this just like you would in a real clinical setting. From the moment a patient shows up with symptoms, all the way to a solid diagnosis that sets up their entire care plan.
So, first things first. Before we can start sorting heart failure into different buckets, we have to be on the same page about what it actually is. Let's nail down the core problem.
The key thing to remember is that heart failure isn't really a single disease. It's a syndrome. It's what happens when the heart just can't keep up with what the body needs. This could be a problem with pumping blood out, we call that systolic dysfunction, or it could be a problem with the heart filling up with blood, which is diastolic dysfunction. Either way, the end result is a cascade of issues for the patient.
So what does this cascade of issues look like when a patient walks into your clinic? Well, you're going to see the classic signs. They'll tell you they're short of breath. Maybe they wake up at night gasping for air, or they've got swelling in their legs. All of these clues point back to one thing: increased pressures inside the heart, which causes fluid to back up.
Okay, now we get to the first big fork in the road in our diagnostic journey. And believe it or not, it all hinges on one single crucial number that we get from an echocardiogram. So you've got your patient, you've heard their story, you've done your exam. What is the absolute first question you need to answer to start putting them into the right category?
And the answer is the left ventricular ejection fraction, or LVEF for short. It's that simple. This 1% tells us how well the left ventricle is squeezing, and it's our #1 tool for that initial classification.
It's pretty amazing, actually. That one number acts like a sorting hat, immediately sending our patient down one of 3 very distinct clinical paths. And each of these paths has different causes, different mechanics, and, most importantly, totally different treatment playbooks.
Path number 1, if that LVEF is 40% or less, boom, you're in the HFrEF bucket. That stands for heart failure with reduced ejection fraction.
Now, if the LVEF lands in that middle zone, from 41 to 49%, that patient falls into the HFmEF category, or heart failure with mildly reduced ejection fraction. It's its own unique group. And finally, what if the squeeze looks, well, normal? If the LVEF is 50% or higher, we're dealing with HFpEF, heart failure with preserved ejection fraction. The pump seems to be squeezing fine, but there's definitely still a big problem.
This slide breaks it down perfectly. The easiest way to think about it is this. HFrEF is a weak pump problem. It's a systolic dysfunction. The ventricle can't contract well, often because of something like coronary artery disease. HFpEF, on the other hand, is a stiff pump problem. It's a diastolic dysfunction. The ventricle squeezes okay, but it's too stiff to relax and fill properly, which you see a lot with long-term hypertension. So what about that middle child, HMEF? Well, these patients are kind of in a gray area, aren't they? They often have features of both the weak pump and the stiff pump. Now, when it comes to treatment, we often lean on the strategies for HFrEF. But it's really important to know the evidence there isn't quite as rock solid. It's a field that's still evolving.
So look, LVEF gets us our main category, but that's just the beginning of the story. To really get a full picture of the patient's experience and how their disease is progressing, we need to add a couple more layers to our classification.
These two systems give us really different but equally important information. Think of the NYHA class, the New York Heart Association class, as a snapshot of how the patient feels day to day. It can get better, it can get worse. But the ACC/AHA stage, that tells the long-term story of the heart's structure. And that story only moves in one direction forward.
Okay, let's get to the payoff. Why do we go through all this? Because it all builds up to the most important part, using this detailed classification to figure out exactly how we're going to treat our patient.
And this is the whole point, right? This isn't just some academic exercise we're doing. Getting the classification right, combining the LVEF, the NYHA class, and the ACC/AHA stage gives us a literal roadmap that tells us exactly which life-saving therapies to reach for.
For a patient with HFrEF, this is the goal. This is the Mount Rushmore of therapy. We call these the 4 pillars of guideline-directed medical therapy, and every single one of these drug classes has been proven over and over to help people live longer and stay out of the hospital.
But for HFpEF, the stiff heart problem, the game plan looks different. Here, we're really focused on controlling symptoms with diuretics, getting that blood pressure way down. And now, thanks to some great new evidence, using SGLT2 inhibitors, which are a real game changer for keeping these folks out of the hospital.
And that's really the key takeaway here. When you methodically work through this framework, starting with LVF, layering on functional class and stage, you can walk away confident that you are applying the right evidence-based therapies that are proven to work. It's your guide to optimal patient care.
So we'll end with this thought. Getting the classification right is the critical first step, but it's not the end of the road. It's actually the starting line. It's what leads you to the next set of questions. How do I titrate these medications? What does the patient need to know? And how do we manage this for the long haul?